Now let's look at hyperkalemia, a life-threatening disorder that can result in cardiac arrest and death when diagnosed and treated late. Hyperkalemia is defined as a serum potassium higher than 5 milliequivalents per liter. Potassium is a primary intercellular cation, or a positively charged ion, and it is necessary for the maintenance of cell metabolism and cell survival. It exists in small concentrations outside the cell, which accounts for its narrow, normal serum range, 3.5 to 5.0 milliequivalents per liter. Potassium is vital for the normal transmission of impulses in smooth, skeletal, and cardiac muscle. Hyperkalemia that is undiagnosed can result in death, especially when the onset is rapid. A serum potassium of 7.0 milliequivalents per liter or higher requires emergent attention. What are the 4 major causes of hyperkalemia? The most common cause is decreased renal excretion of potassium due to renal failure. The kidney is the primary organ of potassium regulation in the body and is vital for the maintenance of normal serum potassium levels. Aldosterone is the hormone that is secreted by the adrenal cortex. Adrenal insufficiency in Addison's disease results in decreased cortisol and aldosterone secretion and potassium retention. Hyperkalemia can also be caused by excessive dietary intake, but is uncommon unless renal function is impaired. Shifts of potassium from the intercellular space to the extracellular space can cause hyperkalemia. This can result from cell destruction, alterations in insulin production, and acidemia. Keep in mind that pseudo-hyperkalemia, a false serum potassium elevation, is likely if the blood in the specimen tube was hemolyzed. If the accuracy of the laboratory result is questionable, the specimen should be redrawn and a heparinized collecting tube used. Identification of risk factors is the key to delivering safe and effective care for clients prone to developing hyperkalemia. While this is true for all electrolyte disorders, the risk of death with acute potassium elevations is very high and compounds the need for early intervention and treatment. The most common risk factors are impaired renal function, causing decreased renal excretion of potassium, cell destruction, the liberation of potassium from inside the cell as a result of burns, surgery, or trauma, rhabdomyolysis, heat stroke, seizures, acute excessive exertion, hemolysis from blood transfusion reactions, sickle cell anemia and crisis, metabolic acidosis when potassium shifts out of the cell, insulin deficiencies because they block the entry of potassium into the cell, type 1 and 2 diabetes, drugs that block renal excretion of potassium, such as the potassium-sparing diuretics like spironolactone, trade name aldactone, ACE inhibitors, angiotensin II inhibitors, tetracycline, NSAIDs, cyclosporin, and heparin, increased dietary ingestion of potassium from herbal supplements, salt substitutes, low-sodium diets because they can be high in potassium, increased consumption of bananas and citrus fruit, and alternative food choices common among those who have eating disorders, and Addison's disease due to the decreased cortisol and aldosterone secretion. The signs and symptoms of hyperkalemia are nonspecific, although they are usually muscular or cardiovascular in origin. Fatigue and weakness are often the earliest signs. What are some other signs and symptoms? Nausea, diarrhea, abdominal pain, paresthesias such as numbness and tingling, muscle weakness, flaccid paralysis, vital sign changes, specifically tachypnea due to respiratory muscle weakness, and bradycardia. ECG changes, including complete heart block, peaked T waves, prolonged PR intervals, widened QRS complexes, loss of P waves due to sinus node arrest, idioventricular rhythm, asystole, ventricular fibrillation or ventricular tachycardia, oliguria, anuria, and a fixed specific gravity. The diagnosis of hyperkalemia cannot be based on physical findings alone because the signs and symptoms are so nonspecific. Serum potassium levels and monitoring for hyperkalemia. Induced ECG changes provide direction for management of the imbalance. BUN and serum creatinine should be assessed with regular frequency. In high-risk clients, elevations in either of these tests can indicate renal insufficiency and renal failure. Serum creatinine is more indicative of renal dysfunction than BUN is. Hemoglobin, hematocrit, and creatinine kinase are blood tests helpful in identifying hemolysis. An arterial blood gas analysis will determine the client's pH. and blood sugar analysis provides information about diabetes control. Management of hyperkalemia depends on the severity of the elevation and the rapidity of onset. An acute onset of hyperkalemia can be life-threatening. A serum potassium higher than 5.5 milliequivalents per liter indicates administration of drugs that increase potassium elimination or move extracellular potassium to the inside of the cell. It might also be necessary to protect the cardiovascular system while hyperkalemia is being corrected. Evaluate the client's response to treatment by observing for increased muscle strength, an improving ECG, and a dropping serum potassium. Some of the therapies used in the treatment of hyperkalemia are hypertonic dextrose and regular insulin IV to shift potassium into the cell, sodium bicarbonate IV to shift potassium into the cell, calcium gluconate IV to protect the heart, beta agonist administration IV, sodium polystyrene sulfonate, trade name Kxalate, orally, NG, or via enema for potassium elimination in the bowel, and hemodialysis to eliminate potassium from the bloodstream. You can prevent hyperkalemia by identifying high-risk clients and detecting signs and symptoms early. Additional strategies for prevention are to evaluate serum potassium levels frequently in high-risk clients, monitor urine output, daily weight, and intake and output, observe the ECG for changes, indicating a rise in potassium, perform and document a thorough neuromuscular assessment so that you can spot changes in baseline assessment findings early. Hyperkalemia is a life-threatening imbalance that can result in cardiac arrest and death if not recognized and treated early. Client safety depends on your comprehensive use of the nursing process, early detection, and intervention.